আসসালামু আলাইকুম প্রিয় চিকিৎসকবৃন্দ। অত্যন্ত প্রাসঙ্গিক, সমসাময়িক এবং জ্বলন্ত একটি টপিক কোভিড-19। আপনারা সবাই কোভিড-19 নিয়ে অনেক কিছু জেনেছেন এবং প্রতিনিয়ত জানছেন এবং এর আপডেট ম্যানেজমেন্ট সম্পর্কে সবাই অত্যন্ত সচেতন। জেনেসিস অনলাইন ইউনিভার্সিটি কর্তৃক আয়োজিত আমাদের আজকের যে ওয়েবিনারে আমি মডারেটর হিসেবে উপস্থিত আছি। আমি ডাক্তার কামাল, ক্রিটিক্যাল কেয়ার মেডিসিন ফেজ বি রেসিডেন্ট, ঢাকা মেডিকেল কলেজ। আপনাদেরকে স্বাগতম জানাচ্ছি সবাইকে। আজকের ম্যানেজমেন্ট অফ কোভিড-19 ন্যাশনাল গাইডলাইন বেসড যে ম্যানেজমেন্ট, আমাদের ম্যানেজমেন্ট নিয়ে স্পিকার হিসেবে থাকবে আমাদের প্রিয় মুখ, অত্যন্ত অনলাইন জগতের অত্যন্ত আপনজন। খুব সুন্দর করে উনি প্রেজেন্টেশন করেন, ডাক্তার নওশাবা নূর আপু। উনি ঢাকা মেডিকেল কলেজ থেকে এমবিবিএস পাশ করে এফসিপিএস মেডিসিন কমপ্লিট করে এমআরসিপি ইউকে কমপ্লিট করে ইসিএফএমডি সার্টিফাইড ইউএসএ হয়ে এখন আপনাদেরকে খুব সুন্দর একটি টপিক আলোচনা করবেন। এবং আমাদের আজকের প্যানেল এক্সপার্ট হিসেবে আজকের যে আয়োজনের মধ্যমণি হয়ে আমাদের মধ্যে উপস্থিত আছেন আমাদের সর্বজন শ্রদ্ধেয় প্রিয় মানুষ, আমাদের খুব খুব আপনজন অধ্যাপক ডাক্তার এম এ জলিল চৌধুরী স্যার এক্স চেয়ারম্যান ডিপার্টমেন্ট অফ মেডিসিন বঙ্গবন্ধু শেখ মুজিব মেডিকেল ইউনিভার্সিটি, স্যার এক্স অনারারি সেক্রেটারি বিসিপিএস। আমাদের মাঝে উপস্থিত আছেন অধ্যাপক ডাক্তার খান আব্দুল কালাম আজাদ স্যার, এক্স হেড অফ মেডিসিন এন্ড প্রিন্সিপাল, ঢাকা মেডিকেল কলেজ, এক্স প্রেসিডেন্ট বাংলাদেশ সোসাইটি অফ মেডিসিন, এক্স ডিন ফ্যাকাল্টি অফ মেডিসিন, ঢাকা ইউনিভার্সিটি। এবং আমাদের মাঝে আজকে উপস্থিত থাকবেন আমাদের প্রিয় স্যার অধ্যাপক ডাক্তার রিদওয়ানুর রহমান স্যার এক্স হেড ডিপার্টমেন্ট অফ মেডিসিন, শহীদ সোহরাওয়ার্দী মেডিকেল কলেজ, এবং স্যার বর্তমানে হেড অফ রিসার্চ ইউনিভার্সাল মেডিকেল কলেজ এন্ড রিসার্চ সেন্টারে কর্মরত আছেন। আমি এই মুহূর্তে আমাদের যে ন্যাশনাল গাইডলাইন বেসড ম্যানেজমেন্ট অফ কোভিড-19 প্রেজেন্ট করার জন্য আমাদের শ্রদ্ধেয় প্রিয় ডাক্তার নওশাবা নূর আপুকে সুনির্বন্ধ অনুরোধ করছি। ডাক্তার নওশাবা নূর আপু, আপনি আপনার প্রেজেন্টেশন শুরু করুন প্লিজ।
Thank you so much, Kamal bhai, for a nice introduction of mine. So, respected and learned panel of experts, my respected teachers, fellow colleagues, and webinar participants. Assalamu alaikum and good evening. I'm Dr. Nawsabah Noor, working as a registrar at Popular Medical College right now. So today, and I like to highlight on a very important topic, that is the management of COVID-19, and it is a very time-appropriate topic. As a physician, we all should be up to date about it. And I would like to highlight mainly on the national guideline that is elaborately prepared regarding the every case management of the COVID-19. So let's have a look on the national guideline-based management of COVID-19. So first, I would like to highlight on a few statistics of our Bangladesh. You know that every day the detection number, detection rate, the death rate are going high and high. Every day we are breaking the records from previous day, previous week. If you look at the statistics of 2 days, that over last 24 hours, the total case detected were more than 12,000, and the death toll was to more than 200. And if you look at this graph, that we are seeing that we are getting higher and higher on the number of detection and number of death toll. So we are going through the third wave of pandemic right now, and we are struggling a lot. We have lost so many souls, so many physicians during this 1 year of pandemic. By showing the respect and utmost prayer to this departed soul, I would like to start today's presentation. So first, I would like to say a few words about the guideline. There are a number of guidelines that are available in the websites of the DG Health, and I must appreciate the effort of them to make an elaborate guideline from every aspect, from the mental health, for the mothers, from the gynecological perspective, from ICU care, and also the national overall management of COVID-19 management. So these are the number of guidelines that are easily available in the website. And I would like to highlight mainly on this, which is the latest version, and which is published on the month of May. It is the 9th version. The first version was published last year, March, and from time to time, it's got updated on the basis of the evidence and scientifically sound recommendation from all around the world. So let's start. So I would like to start with the classification of COVID-19 cases that is been present in our guidelines. So there are basically 5 types of cases, like asymptomatic, mild case, moderate case, severe case, and critical case. And any young physician who are present today must have the clear conception of every case definitions of these several categories, critical categories of the COVID-19 cases. So first, the asymptomatic. As you can see with the name, there is no symptoms is present, but the patient tested positive. We would say a mild case when the patient have the symptoms of influenza-like illness, like fever, cough, loss of taste or smell, myalgia, fatigue, anorexia, headache, ageusia, diarrhea, vomiting, rhinorrhea, sore throat, red eye, abdominal pain, or skin lesion. This list, I would say, is very important because there are a number of cases right now around us, around even in our families. So whenever a patient comes with any of these symptoms, we should think about the COVID first. So you should have that keep in your mind. Next, come to the moderate case. When we say a patient is having the moderate category of COVID-19, if in adolescent and adult patient, if we have got the clinical features of pneumonia, like fever, cough, dyspnea, or fast breathing, here the respiratory rate would be less than 30 breaths per minute, but the saturation will be normal, above 90% on room air. And in children, we would say the baby is in a moderate category when the baby has the features of pneumonia, that is the cough, difficulty breathing, fast breathing, or chest indrawing, but there would be no sign of severe pneumonia. And in case of baby, we would count fast breathing in the following way. Like if the baby is less than 2 months, then the rate would be above 60 breaths per minute. 2 to 11 months, if it's above the 50 breaths per minute, then we'd say it's fast breathing. And if the baby is 1 to 5 years old, then the rate would be more than 40 breaths per minute. Now come to the chest imaging. We shouldn't go for any chest imaging for the diagnosis of moderate category. We will always try to make the diagnosis of clinical ground. But yes, we can go sometimes to clinical chest imaging like X-ray, ultrasonogram, HRCT, but they only assist in the diagnosis and helps us to identify the pulmonary complication. Now come to the severe case classification. When we say a patient has severe category, when the adult or adolescent patient has the features of pneumonia that we have discussed before, along with that, he will have the complaint of severe respiratory distress. And here the respiratory rate would be above 30 breaths per minute. And the saturation would be below 90% in room air. So this is very important, the respiratory rate and saturation, which actually differentiate severe cases from the moderate category. And in case of children, similar like the before, like the baby will have the features of pneumonia. Along with that, at least one criteria should be present, like central cyanosis, saturation below 90%, severe respiratory distress like fast breathing, grunting, very severe chest indrawing, or general danger sign like inability to breastfeed or drink, lethargy, unconsciousness, and convulsion. If any one of these are present along with the features of pneumonia, in that case, we would suspect this baby has a severe case of COVID-19. Now come to the critical case definition. When a severe COVID-19 case is meeting any of the following criteria, then I would say that this is a case of critical COVID-19. What are those? Like the respiratory failure and requiring mechanical ventilation, sepsis, septic shock, ARDS, that is acute respiratory distress syndrome, or any organ failure that requires the ICU care. So this is another one. If the pregnant woman is present with us with a saturation below or at 94%, then we would consider it severe category in pregnant women. So now come to the risk factors. This is the risk factors that are present, and we should have a very good knowledge about this risk factor, because any patient who has these risk factors, that there is some changes in the management, and we have to keep our eye open for that, because they might the patient with this risk factor might die or may result in severity because of this COVID-19. What are those risk factors? Diabetes, hypertension, high risk pregnancy, chronic kidney disease, asthma, COPD, obesity, malignancy, chronic liver disease, ischemic heart disease, heart failure, dementia, mental disorders, stroke, on steroid, and chemotherapy. Now come to the triage. Like whenever, right now, in every hospital, there is a separate system. Like one portion is dealing with the COVID and another portion dealing with non-COVID patients. So in the triage, it is very important that how we will classify the patient and send the patient accordingly to the COVID unit, or when we send the patient to the non-COVID area. So first we will look for the symptoms of COVID-19. This is the list of symptoms that I have discussed before. And after that, if there is no presence of COVID-19, then the COVID-19 is unlikely, and then in that case we refer the patient to non-COVID section of the hospital. But if the patient has those features that we have discussed before, then we would say that is it a suspected case of COVID-19 or it is confirmed case of COVID-19. COVID-19 if the test comes positive. Then we have to clinically evaluate the patient and classify. Here you can see the criteria is based solely on the clinical features. We are not talking about the imaging. Still, we are not talking about any imaging itself. Why I am highlighting it more? Because nowadays we are seeing that many patients are come with HRCT, chest X-ray, like on their own. All these tests are by their own selves. So we will discuss a bit about it today. So then we will have to clinically evaluate it, and we will look for whether the patient has any visible respiratory distress. Is the respiratory count is above 30? If it's 30, then it is goes with severe category. If it's below 30, then it's moderate category. If the saturation is below or at or below 93%. If the patient looks unwell, or is there any absence of other possible cause, then we would classify it moderate, severe, or critical illness. And then we have to admit the patient and start oxygen from tragedy if saturation is below 90%. For critical cases, we start resuscitating the patient at tragedy, and we would contact the ICU or H2 for referral center for vacancy, because ideally the critical patients with COVID-19 should be managed in the ICU. But if we, in the evaluation, we have seen that the patient doesn't have any respiratory distress, normal clinical examination, saturation is fine, no tachypnea, and can do usual activity, then we designate as a mild case, but no need for admission except in specific conditions. And we will go for antigen testing, and if the test comes negative, then we advise for RT-PCR, and then we manage the case according to mild case protocol. Now come to the admission criteria. Whom patients we would advise for hospitalization. If all the cases are moderate case, if he has the evidence of clinical or radiological evidence of pneumonia, if the patient goes into severe category that we have discussed before, and if the patient is critical category. If the patient has hypoxia, that is at or below saturation is 93% without any clinical features, that we call the happy hypoxia. And another one is patient with comorbid or prothrombotic state. The comorbids that we have discussed before, prothrombotic state, for example, high risk pregnancy, ongoing malignancy, this kind of patient, we should admit those in the hospital. Now come to the clinical management of COVID-19. I think the most, everyone is waiting for this discussion, I guess. So first come with the asymptomatic patient. We have to keep in the mind, no symptoms, no treatment. Okay, so whenever we are dealing with an asymptomatic patient, we just only advise for isolation, strict isolation protocol, that he has to be isolated at home. And if he has, as we are dealing with asymptomatic patients, so we guess he doesn't have any symptoms. Then there is some advice from home isolation. What are those? Like rest at home in self-isolation, that we have to counsel the patient very well, that he have to remain isolated. And if there's a chance that patient can remain isolated, then he can be hospitalized. Suppose the patient doesn't have any caregiver at home, the house is overcrowding. In that case, the patient can be hospitalized and keep isolated in a designated area. In the home, he has to maintain physical distancing with family members. No visitors should be allowed. Regular hand washing for at least 20 seconds. Cough etiquette should be maintained, that the use of the elbow or tissue during coughing, and medical mask is must for both the patient and caregiver. Now come to the mild cases. So if we have a case with mild cases without any comorbidity, then we will treat the patient at home isolation that we have discussed before, and we also provide the symptomatic management. If patient comes with mild category, but he has controlled comorbidity, in those patients can be also managed at home. But careful monitoring is required here. We are going to discuss it in detail later. And if the patient has multiple uncontrolled comorbidities and also the prothrombotic state, in that case, the patient must be admitted, and along with the symptomatic management, we should also provide the thromboprophylaxis treatment. Now come to the medication that we usually prescribe in mild cases patient. The first, these are all actually symptomatic management. Like for fever, we'll give the paracetamol. If the patient has rhinorrhea, we can give the antihistamine. If the patient has cough, antitussive can be given for dry cough. And inhaled budesonide 200 microgram 2 cup 12 hours is also been given for treatment of cough. Thromboprophylaxis that I have mentioned before, if the patient has uncontrolled comorbidities or prothrombotic state, in that case, we must provide thromboprophylaxis along with the symptomatic management, and also we advise the patient for hospitalization. How the thromboprophylaxis will be given, the drug of choice is enoxaparin. The dose is 40 milligrams subcutaneous once daily. But if the patient is obese, that means BMI is more than 40, in that case, the dose will be double, like 40 milligrams twice daily. And if the creatinine clearance is below 30 ml per minute, in that case, the dose should be halved. Like enoxaparin is 20 milligrams subcutaneous once daily, or and another choice can be unfractionated heparin 5,000 ml subcutaneous twice daily. Now come to the monitoring. As I mentioned earlier that we have to make a careful monitoring of the mild cases patient at home. We have to have a good look on the oxygen saturation, especially at rest and with minimal exertion, especially if walking for 3 to 6 minutes, we have to measure the oxygen saturation. Is there any fall or any variability? We have to counsel the patient above this danger sign. Like if he develops any of these danger signs, he can't wait at home, he must go to the hospital. What are those danger signs? Breathing difficulty, chest pain, lightheadedness, disorientation, extreme tiredness, and oxygen saturation at or below 93%. So we have to be very, very careful about counseling about this danger sign to our patient, because most of the patient, as we know, that COVID-19 cases, around 80% cases are in mild category, and they can be treated at home. So we have to counsel the patient very well about these possible danger signs. Now come to the investigation. Should we go for any baseline investigation in mild cases? No, no investigation is required in case of mild cases. We have to keep that in our mind. Now come to the moderate case management. So what would be the initial management? The symptomatic management that we have discussed before, and oxygen. Sometimes in moderate cases, we need to give some oxygen. The oxygen can be given with a nasal cannula, maximum with which the maximum 5 liters per minute can be provided. And what would be our target saturation? Our target saturation will be 94% during the initial resuscitation and 90% in case of stable patients. So we have to remember this in our mind. Like when the patient comes to us and we got admitted in the triage area or in the initial resuscitation period, the target is 94%. But in stable patient, the target is 90%. In case of pregnant patient or pregnant patients with organ failure, the target is 94%. And we have to advise the proning, which would be for 4 to 6 hours per day. We can divide the time from for the day, but we have to advise for proning. This is we can see the patient is in the prone position. Now come to the thromboprophylaxis. In moderate case, we have to advise for thromboprophylaxis. The drug of choice is enoxaparin, low molecular heparin at a standard dose of 40 milligrams subcutaneous once daily. And if obese patient, that dose would be twice daily, 40 milligrams subcutaneously. If the creatinine clearance is 30, the dose would be halved, that is 20 milligrams subcutaneous once daily, both for obese and non-obese patient. And if we can't use the low molecular heparin or the patient does have any contraindication, in that case, we would use unfractionated heparin 5,000 ml subcutaneous period. Duration. So how long we have to continue this thromboprophylaxis? We need to continue the thromboprophylaxis until discharge or 7 days. As we have mentioned before, that moderate case patient should be admitted in the hospital. So until discharge, we have to maintain this thromboprophylaxis, or 7 days, whichever is longer, we have to do that. And after that, we have to give oral anticoagulant, that is tablet rivaroxaban 10 milligram once daily, or tablet apixaban 2.5 milligram twice daily. And the duration is 1 month, especially if the patient at risk for thromboembolism based on clinical description. So after a while, we are seeing the examples of rivaroxaban, apixaban here, but in our clinical practice, sometimes we see the patient comes with the clinical symptoms and staying at home, but they have started taking the DOAC, the direct oral anticoagulant. No, this is not actually recommended in our national guideline. It is clearly recommended if the patient got admitted in the hospital because of its moderate or severe category. In that case, thromboprophylaxis should be given initially by the low molecular heparin, and after discharge, we will give the direct oral anticoagulant for a month. Now come to the role of antiviral. Remdesivir can be given in case of moderate case, and it should be given 10 days of the symptoms onset, and it should be always at the discretion of the consultant in the hospital, and in whom patient should be given in any adult and pediatric that is above 12 years of age patient in suspected or laboratory confirmed COVID-19 case who is hypoxic, that is 93, saturation is below 93, having increased breathing difficulty, or who needs oxygen. What is the role of steroid? Steroids should be given, and moderate cases if the patient has respiratory distress and the hypoxia, that is saturation below 93%. And what would be the dosing? The dosing is dexamethasone 0.5 milligram. It can be given orally. So in that case, the 12 tablets should be taken. So the dose is 6 milligram. So we can give this in moderate case. Steroid can be given orally. Now come to the antibiotic. There is no role in antibiotic in COVID-19 infection, but still oral antibiotic can be given in moderate case. The amoxicillin, clavulanic acid, or doxycycline can be given when bacterial infection is suspected. Investigation. What investigation would advise in case of moderate case? This is the list of investigation: complete blood count, CRP, D-dimer, LDH, ferritin, creatinine, ALT, chest X-ray, PAVU, or HRCT, and others marker as per treating clinician decision. Now come to the severe case management. It's the symptomatic management that we have discussed before. Oxygen therapy, escalate the oxygen flow as per patient oxygen saturation and degree of respiratory distress. And there is a different number of oxygen delivery device. We will start with nasal cannula, then we will go for oxygen mask, then non-rebreather bag with reservoir bag. Non-rebreather bag with reservoir bag. Immediate administration of supplemental oxygen should be given. In case of patient with emergency sign, the target saturation should be above 94% during resuscitation. And without emergency sign and hypoxia, saturation should be kept above 90%. And in case of pregnant women, the target is 92 to 95%. Now proning. We will also advise proning in severe cases. Here the 4 to 6 hours per day or more, but we can avoid proning in case of if the patient severely dyspneic, any contraindications present. In this case, we should, in the cases where we can advise proning, we can try lateral or sitting position. Steroid. In severe cases, we must give dexamethasone in IV route. When the dose is 6 milligram once daily for 7 to 10 days. And we have to maintain euvolemia and avoid fluid overload. Now come to the antipopulation severe case. We should initiate thromboprophylaxis at standard dose, that is the 1 milligram kg per 1 milligram per kg per day, and we should also assess for the bleeding risk. And therapeutic anticoagulants, that is the should the anticoagulant should be used at therapeutic dose. There is actually a lack of evidence of using the therapeutic anticoagulation dose in severe cases. The therapeutic anticoagulant dose is 1 milligram per kg body weight 12 hourly, and it can be given only if the patient has proven thromboembolism or suspected thromboembolism. So in that case, our dose is 1 milligram per kg per body weight 12 hourly. That means twice daily. Or other cases, in severe cases, we should give the thromboprophylaxis 1 milligram per kg per day. How long we would continue the anticoagulant? Just like moderate case, until the discharge or 7 days, and after that we will provide the direct oral anticoagulant for a month. Now antiviral, same like moderate case, remdesivir should be given, and it should be given to the 10 days of the symptoms, and this is the clinical category that I mentioned before in moderate case. Now come to the role of antibiotic in severe case. IV broad spectrum antibiotic should be given at the discretion of consultant if bacterial infection is suspected. Now come to the investigation that we suggest in severe case patient. CBC, CRP, D-dimer, ferritin, serum, creatinine, ALT, chest X-ray, and other lab and parameters. Now come to the role of HRCT. HRCT should not be routinely advised, only help in diagnostic dilemma. Suppose we have a patient highly suspected of COVID but RT-PCR kept negative. In that case, you can advise for HRCT, which can help in our diagnosis. We should keep in mind that HRCT does not have any role in the management protocol in COVID-19. Now come to the discontinuation isolation, like how long the patient should maintain the isolation protocol. In case of asymptomatic patient, 10 days after the sample collection. In case of mild cases, 14 days after the symptoms are provided, no fever and decreased respiratory symptom for last 3 days. In hospitalized patient, 21 days after symptoms onset, no fever and decreased respiratory symptom for 3 days. So our rule is 10 days, 14 days, 21 days. So we have to keep that in our mind. What is the discharge criteria of the patient from the hospital? There are some clinical criteria like resolution of fever without the use of antibiotic and significant improvement of respiratory symptoms like cough and respiratory distress for at least 3 days. If we can see these clinical parameters of the patient, in that case, we can plan for discharge. And obviously, the patient physician discretion is very important in case of severe and critical patient. Now you can ask, should I need to go for retesting while giving the discharge to the patient? No, there is no need to give discharge, but we should advise about maintaining the isolation protocol for the duration of days that I have mentioned before. Now come to the sequence of oxygen delivery devices that you use in the hospital. First, we will start with a nasal cannula with which 1 to 5 liter of oxygen can be given. If that fails, then I will go for simple face mask. If the saturation cannot be maintained, then we will go for non-rebreather mask with reservoir bag. After that, high flow nasal cannula, after that, non-invasive ventilation, and lastly, the mechanical ventilation. And this is the goal that we have to maintain in case of mechanical ventilation patient. This is another chart that is been provided in our national guideline regarding the prophylactic, intermediate, and therapeutic dose of anticoagulant. Everywhere, low molecular weight should be given, low molecular heparin should be given, that is the enoxaparin. The dose is prophylactic is, as I mentioned you earlier, 40 milligram subcutaneous once daily. Intermediate dose is 0.5 milligram per kg body weight twice daily, and the therapeutic dose is 1 milligram per kg body weight twice daily. Candidates should be given, prophylactic dose should be given in case of mild cases with uncontrolled comorbid condition or prothrombotic state, and moderate cases. Intermediate dose can be given in severe cases, and therapeutic dose should be considered in critical case patient, and also the patient who has proven thromboembolism and strong clinical suspicion for thromboembolism. Now come to the dose of steroid that can be given other COVID-19 syndromes. ARDS due to COVID, in that case, we should give for injection methylprednisolone 1 to 2 milligram per kg 12 hourly, or dexamethasone can be given. The dose is 20 milligram IV daily for 5 days, then 10 milligram IV daily for 5 days, then 5 milligram IV daily for 5 days. So there is doing a gradual reduction in the doses, as we can see. And in refractory sepsis, injection hydrocortisone should be given 50 milligram 6 hourly. In cytokine release syndrome, injection methylprednisolone can be given 1 to 2 milligram per kg 12 hourly, and injection dexamethasone 10 milligram 6 hourly. Now there is some series of recommendations that has been provided in guideline when we are dealing with critical COVID-19 patient. First, let's highlight few words on respiratory support. COVID-19 and ARDS. Trial of high flow nasal cannula non-invasive ventilation like CPAP, BiPAP may be used. If there is no improvement, further respiratory support should be given, like mechanical ventilation. Prompt recognition of progressive acute hypoxic respiratory failure should be considered if we have a patient who are having respiratory distress despite standard oxygen therapy, or advanced oxygen or ventilator support is needed. Sometimes in our patient, we need to go for endotracheal intubation, but we have to be keep in our mind that it is a aerosol generating procedure, so we have to maintain the airborne precautions, and trained and experienced providers should go for this endotracheal intubation. Mechanical ventilation, if we go for mechanical ventilation, we should keep some parameters in our mind that we have always tried to maintain lower tidal volume, that is the 4 to 8 ml per kg predicted body weight, and lower inspirator pressure, that is the plastic pressure should be below 30 centimeter water. And in case of severe DS, which is defined as a partial pressure of oxygen and E5 to ratio less than 150, aerobic ventilation for 12 to 16 hours per day and conservative fluid management strategy should be maintained. Now come to the septic shock management. We should recognize septic shock when we have an adult or adolescent patient where infection are suspected or confirmed, and vasopressor required to maintain the mean arterial pressure above 65 millimeter mercury, and lactate is above 2 millimole per liter in the absence of hypovolemia. And this is the parameters that we should consider in children when we suspect the septic shock. Now, resuscitation of septic shock. In case of adults, we should resuscitate with 250 to 500 ml crystalloids at rapid bolus in 15 to 30 minutes. In children, 2 to 20 ml per kg crystalloids as bolus in the first 30 to 60 minutes. And these are the fluids are not recommended for resuscitation. Or what are those? Hypotonic crystalloids, starches, or gelatin. Now come to the role of vasopressors. In adult, when shock persists during or after fluid resuscitation, we should go for vasopressor, and our target is to maintain the mean arterial pressure above 65 millimeter mercury and improvement of marker of perfusion. And this is the recommendation where in the children, in case of children, that when we should go for vasopressor. Now, I would like to say a few words about recommendation about some few other antiviral recommendation about some other drugs that are being used in different phases of COVID-19. First, tocilizumab. It is not routinely recommended, but it can be given under consultant supervision if clinical and certain biochemical criteria fulfilled. What are those? The clinical criteria is the patient must be adult, that is above 18 years of age. The patient is admitted to the ICU within the last 24 hours and require invasive mechanical ventilation or non-invasive ventilation or hypronasal cannula, and requiring above 30 liter per minute oxygen with FiO2 more than 0.4%. If these clinical parameters are met, or if we get the biochemical parameter, that is CRP over 75 milligram per deciliter, in that case tocilizumab injection should be considered. What is the dose? Dose is 6 milligram per kg, maximum is 800 milligram per dose, can be repeated after 12 to 24 hours, and maximum 2 doses. What are the contraindications of using the tocilizumab? If there is a significant immunosuppression, like for example, recent use of other biologics or immunomodulating agent, if the liver function test, that is the ALT is above 5 times the normal, high risk of gastrointestinal perforation, uncontrolled serious bacterial, fungal, or non-SARS-CoV-2 viral infection, absolute neutrophil count less than 500 cells per microliter, and platelet count less than 50,000. Paracetamol is an example of JAK inhibitor. When we will give the paracetamol, if we have a hypoxic patient where steroid cannot be used, in that case we should go for paracetamol. The dose is 5 milligram once daily for 14 days, should be given as an add-on to remdesivir. We should also keep that in mind. So paracetamol should be given where steroid cannot be used and the patient is already receiving remdesivir. Only in those cases we should go for paracetamol. Use of paracetamol alone is not recommended unless there is a specific clinical trial. Convalescent plasma, what is the recommendation? No high quality evidence to recommend the use of convalescent plasma. What about the ivermectin? Nowadays, we are seeing a lot of patients. I can see that many patients are taking ivermectin once a day, once a month as a prophylactic, and various kind of recommendation I'm seeing around the people around me in the community. So what the recommendation is saying about the ivermectin? No quality evidence suggesting any role of ivermectin treating any grade for treatment or any grade of severity of COVID-19 or preventing the COVID-19. Can only be used in the context of clinical trial. This is actually highlighted in the WHO recommendation. I am going to highlight few points from there. Later I will touch those things. Now come to the bevacizumab. No high quality evidence of using COVID-19 can only be used in the context of clinical trial. So this is the recommendation about bevacizumab. So I know many of you might be going through this phase right now because this is almost dinner time and I'm taking long, but my national guideline portion is kind of finished, but I would like to highlight few more things that needs to be updated right now considering the situation. If my teachers permits, with their permission, I want to proceed. Thank you, sir. Okay, I won't keep you long. Just keep calm and few more slides. So I would like to touch the very important topic, that is mucormycosis, regarding which our guidelines recently published on 6th June. We know that mucormycosis is a very serious fungal infection, though it rarely happens. But due to this COVID-19 time, we are seeing a lot of patients of mucormycosis, especially in India. Until the end of May, like around more than 8,000 cases has been reported with this mucormycosis, what they labeled as black fungus. And in our country, so far, 7 to 8 cases has been detected. So this is a very common fungus that is present in the environment, but we don't commonly get. It usually comes in the patient or presents in the patient with known risk factors. What are those? Like uncontrolled diabetes, who are on severe immunosuppressive medication, or immunomodulators, who are going through any transplant or bone marrow suppression, or having severe neutropenia. And in case of COVID-19, as we are using the steroids, so it causes the immunosuppression, we are using immunomodulators. So these are the risk factors for mucormycosis in case of in patients with COVID-19. And it presents in several ways. The most common one is rhinocerebral mucormycosis. Next, the pulmonary one, gastrointestinal and cutaneous variety is also present. So how would we diagnose the mucormycosis, and when we suspect a case of mucormycosis? If there is a history of severe COVID-19 in the past 2 to 4 weeks, if the patient has a complaint of sinusitis like nasal blockage, nasal discharge, cheekbone pain not responding to the medication, if there is a features of unilateral facial swelling, or there is a blackish discoloration over nose or talons, if the patient has features of chest pain, pleural effusion, hemoptysis, worsening of respiratory symptoms, if we have any patient with recent history of COVID-19 and we has these features come to us, we should to think about the mucormycosis. And how will you diagnose it? The investigation, the most important investigation is important for the diagnosis is the biopsy with histopathology examination. It is a biopsy. It is not a swab. You should have to keep that in your mind. And we should also go for radiology to see the extent of the involvement, like CT scan or MRI of the orbit in case of rhinocerebral mucormycosis, HRCT test in case of chest in case of pulmonary mucormycosis, MRA, MRV, CTS, CTV in case of cerebral venous sinus thrombosis. And baseline investigation should be done. Most important one is serum creatinine and electrolytes. We should monitor this investigation on weekly basis to see the involvement and also see the toxicity of the treating medication. So how will you manage the patient with mucormycosis? It should be treated at a tertiary hospital with multidisciplinary approach. In our team, there will be internists, surgeons, or ophthalmologists, ENT surgeons, and many more. Correction of the underlying risk factor is very important. Like if we going through the steroid, we will try to reduce the dose. If we are going through any immunomodulating drugs, we should try to stop that medication. So we will try to control our underlying risk factors. And another very important risk factor is diabetes, the control of the glucose in the diabetic patient. Early and complete surgical debridement of the involved tissue is very important. And next, the systemic antifungal therapy should be given. The first choice is liposomal amphotericin B. The dose is 5 mg per kg daily, administered as an infusion over 2 hours. And the patients, if the patient comes with CNS features, in that case, the dose should be 10 mg per kg. But if the patient cannot tolerate this 5 mg per kg dose, in that case, we will give the medication on alternate basis. And how long we have to maintain the medication depends on the clinical situation and may take several weeks to months. 1 liter of saline should be given a day to reduce that risk of nephrotoxicity. And the other choices are amphotericin B, deoxycholate, posaconazole, or isavuconazole. And now I'd like to highlight a few more slides beyond our guidelines. What are the updates, or I would say what are the recommendations? So recently, actually, therapeutic and COVID-19 management living guideline has been updated, which has been provided by the WHO. These are the previous recommendations. That was, most of us know about these things, and our national guideline actually based on this recommendation. Like they have this recommendation not to use the ivermectin, strong recommendation against hydroxychloroquine, strong recommendation against lopinavir, ritonavir, conditional recommendation against remdesivir, strong recommendation for systemic corticosteroids. So these are the recommendations comes in the previous versions or previous updates of this guideline. The latest one is published in July 6, 2021, and their recommendation is strong recommendation to use interleukin-6 receptor blocker, that is the tocilizumab or sarilumab in severe or critical patient. They have suggested or come to this recommendation after analysis of 100,020 patient in a REMAP-CAP trial, and corticosteroid has previously been strongly recommended in severe and critical patients, and now WHO recommend patient meeting this severity criteria should now receive both corticosteroid and interleukin-6 receptor blocker. So this is the latest recommendation from WHO. This is the study that they have provided, where they compared the result between the standard care and interleukin-6, where they have seen that actually improvement in mortality, mechanical ventilation, and also duration of mechanical ventilation, duration of hospitalization in the group of patients who also gets the interleukin-6 inhibitor in their treatment protocol. So apart from that, I want to highlight another point from WHO that other COVID-19 therapeutics that are currently under consideration by WHO include colchicine, monoclonal antibodies, and anticoagulant. This guideline will be updated if or when sufficient new data warrants this. So their trial about these treatments, colchicine, monoclonal antibodies, or anticoagulants are going right now from WHO. Now, I'm highlighting few points of the monoclonal antibody because we are seeing in the newspaper the number of monoclonal antibodies are being used around the world, which varies from country to country. I take the recommendation of these slides from NIH. They recommend to go for this monoclonal antibody, casirivimab plus imdevimab. This is also known as the cocktail protocol or Rengen-Pov protocol, which is actually given to Trump last year when he got infected with COVID-19. And recently, this cocktail protocol is also being authorized to use in India. The another recommendation by NIH, which is to use the Sotrovimab, which is actually also recently got the endorsement from FDA to being used. So when we can use this monoclonal antibody in outpatient patients with mild to moderate cases who are at risk for clinical progression as defined by the emergency use authorization criteria. So we can use in adult or pediatric patient in mild to moderate cases who are at risk might go for clinical progression. Only on those cases we can go for this monoclonal antibody. Treatment should be started as soon as possible after the patient receive a positive result on SARS-CoV-2 antigen or RT-PCR test, and within 10 days of the symptoms onset, we should use this antibody. And NIH recommend against the use of Memlanivimab plus Itazimab, and they also recommend not to use this monoclonal antibody in hospitalized patient. I just want to add another thing. This medication, this combination monoclonal antibody is approved in FDA, and it is also being used in USA. But NIH actually recommend against to use because it actually helps in the development of the variants. That's why they recommend against to use that. And intravenous, regarding the intravenous immunoglobulin against COVID-19, the NIH said that there is insufficient evidence to recommend the use of IVIG. So I am coming to the conclusion. Actually, I would like to convey my thanks once again to the DG Health and also the editorial board who actually worked relentlessly for the development of the national guideline, which actually helps the young physicians like us throughout the Bangladesh and help us to go treatment for COVID-19 patient on scientific evidence. And also, I feel honored today to present the guideline in front of those teachers with whom, with their magic of their hands, actually this guideline was being made. So I feel really honored. So actually, regarding the COVID, I would say that every day is a new day. Maybe after this presentation, I might think, or the participant might think, yes, we all know about all the updates of the guideline. No, every day is new day in COVID. Every day is the treatment management. Everything is progressively changing. So we have to stay updated. And secondly, I want to say that as a physician, we have to always emphasize on this COVID-19 prevention protocol because people are getting frustrated. We are getting bored, like repeatedly saying about using the hand sanitizer, using the mask, but we shouldn't get tired. As a doctor, we have a role to the community, and we always try hard to create awareness regarding this preventive strategy. And last but not the least, the COVID vaccine. There's a number of vaccines are available in our country, and people are very much worried that about the potential side effects, what vaccine might get. We should counsel our people, general people, that they need to get the vaccines because this is one of the important arms or important things we have in our mind to end this pandemic. So we have to come forward in this regard. We are in pandemic darkness right now. We don't know when this darkness will end, but we strongly believe someday new sun with new hope will shine us soon. Till then, stay safe and stay healthy. Thank you very much for patience hearing.